Everyone, my name is Adam Melstrom, and I am a doctoral candidate at AT Still University, and this is my ARP project entitled Blood Flow Restriction Evidence to Practice Review. Moving through my table of contents, I will be going through a brief introduction, going through just some background on blood flow restriction therapy, my clinical problem and question. Then I will be moving into my summaries of literature, intervention, and outcomes, wrap everything up in my findings and clinical implications, move to my clinical bottom line, and then I will share some of my final thoughts and some further research that I think this topic could go towards. Then finally, just share my references. So once again, my name is Adam Melstrom. I'm an athletic trainer working at a NCAA Division II university in Minnesota. I have been an athletic trainer for 6 years, and I am currently in my second season at the university I'm at now. I'm originally from Wisconsin. I moved to Winona, Minnesota after high school to get my bachelor's degree in athletic training from Winona State University, and then moved to Brookings, South Dakota to get my master's degree in exercise science and nutrition from South Dakota State University. My clinical interests include rehabilitation techniques and different approaches to athletic training education. So what is my level of exposure to blood flow restriction? I have only recently been seeing it in my clinical setting, and I have grown more and more curious about it as I see my coworkers utilize it. BFR is a therapeutic intervention that I had seen in our athletic training room and have been seeing desirable outcomes with the patients that my coworkers use it with. So why did I choose to pursue this topic? After seeing those outcomes my coworkers had with their patients, I wanted to learn more about blood flow restriction, and I found that there were many different protocols that exist for utilizing BFR once I started researching it. I've also found that none of the protocols seem to be superior to others, and I continued looking into the therapy and found a lot of information that I felt was important for clinicians to know about and how they could best implement them into their individual practices. A brief background on blood flow restriction therapy. BFR is a form of occlusion therapy that involves the placing of elastic or nylon straps or pneumatic cuffs around a limb to occlude venous return without completely cutting off arterial blood flow to the targeted limb. BFR has also been found to improve muscular strength, muscular volume, hormonal response, and intracellular effects within the muscle. BFR has also been found in some studies to help decrease perception of pain in subjects with musculoskeletal injury. So who uses blood flow restriction therapy? In today's rehabilitation world, athletic trainers, physical therapists, physicians, and occupational therapists are all examples of professionals who utilize BFR. So why would I use it or you use it as an athletic trainer? It can be utilized for a lot of patients, especially patients who have sustained an injury and are unable to perform appropriate rehab due to limitations in strength or range of motion. It can be used pre or post surgical interventions and can also be used on immobilized limbs. It helps patients to improve muscular strength and increase muscular volume, and helps patients to decrease their perception of pain after they have sustained an injury. As I continued my research on blood flow restriction therapy, I came across quite a few clinical problems that I wanted to address. The first was that musculoskeletal injuries and/or surgical treatments are often associated with decreases in neuromuscular capacity, increases in pain, increases in musculature weakness, and increases in muscular atrophy. Blood flow restriction has been shown to address all of these concerns. Next, knee injuries and quadricep weakness have been linked as a major risk factor in musculoskeletal diseases. Blood flow restriction therapy has been shown to help increase the strength of quadricep muscles, which could help combat this risk factor. Finally, resistance training is a widely utilized means of combating these ailments. So what if the patient cannot appropriately perform the resistance exercise? When a patient is unable to perform resistance training, They can utilize blood flow restriction therapy to help promote the same therapeutic effects that they would get from resistance training. But with so many blood flow restriction protocols out there, which protocol would work best for my patient to help rehabilitate their lower limb injury? Beginning my evidence to practice review, I found the original reference by Nitsche et al., The Effectiveness of Blood Flow Restricted Resistance Training in the Musculoskeletal Rehabilitation of Patients with Lower Limb Disorders, a Systematic Review and Meta-Analysis. The authors of this article utilize the following search strategies. They searched for literature examining BFR in the clinical musculoskeletal rehabilitation of the leg. They utilized PubMed, Scopus, Web of Science, and the Cochrane Library. Each database was searched using the following search string: resistance training and blood flow restriction and rehabilitation. To be used in the systematic review and meta-analysis, the authors utilized the following inclusion criteria. The article would only be included if the article included adult subjects with an orthopedic impairment after operation, sustained trauma, and/or had suffered degeneration to the leg. The article needed to be in a randomized controlled trial. It needed to have a comparison between low load blood flow restriction and low load resistance training without BFR, and/or a comparison between low load blood flow restriction and high load resistance training without BFR. The article needed to include targeted outcomes that included muscular strength, muscular cross-sectional area, muscular volume, and/or musculoskeletal pain that was assessed before and after intervention. Finally, the article needed to report a fit criteria of resistance training intervention. Articles were excluded if they met any of the following criteria. Articles were excluded if they were clinical trials involving resistance training with blood flow restriction in patients with nervous system, internal organ, or systemic diseases. Any studies with only acute treatment were also excluded. Case studies and single-arm studies were excluded, and studies that were not published in a peer-reviewed scientific journal or studies that presented results without reporting mean and/or standard deviation in tables or in graphics were excluded from this study. The guiding literature's initial search process identified 496 studies. Of the 496 studies, duplicates and non-full text articles were removed for a total of 27 full-text articles that were assessed for eligibility. 17 full-text articles were excluded due to inclusion criteria not being met or due to the article containing criteria for exclusion. The remaining 10 studies were included and were quality checked using the tool for assessment of study quality and reporting in exercise, or TestX. The average TestX score was 10.8 plus or minus 1.6, with the highest score being 14 by one article and the lowest score being a 9 for 3 articles. Of all of the subjects that were included in the literature, 5 studies were both male and female, 3 studies were female only, and 2 studies were male only. The average age of subjects for the 10 studies was between 31.9 and 47.1 years of age. The youngest subject was 14, while the oldest subject was 69 years of age. 4 studies had subjects who were either pre or post-op ACL reconstruction. 4 studies had subjects who suffered from knee osteoarthritis. 1 study included patients with anterior knee pain, and 1 study included subjects with various lower limb injuries. As necessary for the inclusion criteria, all studies utilized low-load blood flow restriction as their intervention. 6 studies utilized only high-load resistance training as a control. 3 utilized only low-load resistance training as a control, and 1 study utilized 2 control groups, one control group being low-load resistance training only, and the second control group being high-load resistance training only. The modes of exercises included in these studies were leg press in 3 studies, leg press with knee extension in 3 studies, single leg press in 1 study, isometric knee extension in 1 study, and body weight exercises in 2 studies. Here's a table breaking down my summary of the interventions. Here I have broken down the durations of each of the 10 studies. You can see that the longest duration was 16 weeks, while the shortest duration was 2 weeks. Average duration for each study was 7.1 weeks, and the most common length of duration was 8 weeks, which was utilized in 3 studies. The randomized control trials included in the guiding review averaged 3.3 days per week. The most common exercise prescription included blood flow restriction training twice a week, and that was found in 4 randomized controlled trials. The least common protocol, existing in only 1 of the randomized controlled trials, had subjects performing blood flow restriction 6 days a week. In the randomized controlled trial that had subjects performing BFR 6 days a week, they also had subjects performing BFR 1 to 3 times a day. This study was the only one that adjusted their protocol as they progressed through the study. The most common frequency was to perform BFR once per intervention day. Of the 10 studies included, the most common frequency combination was 1 training session per day, 2 days per week, for a total of 2 BFR sessions per week. The intensity of the randomized controlled trials varied by quite a lot. The most common prescription included having the subjects perform 4 sets of exercise. The first of these sets included 30 repetitions, while the following 3 sets included 15 repetitions each. These studies also all only allowed 30 seconds of rest between each set. Here I have highlighted the 3 studies that included this 4 sets of exercise. You can see that the first set includes 30 repetitions, while the following 3 include 15 repetitions. Here I have highlighted 2 other studies. There was mention of performing 4 sets of exercise over the course of 5 minutes. These 2 studies were performed by the same authors. They performed the same study twice. The first study was on male-only subjects, and then the second study was done on female-only subjects. They used the same protocol for both studies and stated that they had subjects perform 4 sets of exercise within 5 minutes. When looking at the actual article, they state that they followed the 30-15-15-15 scheme, but they assigned 2 minutes to the first set and 1 minute to the following 3 sets. They also state that they allowed for 30 seconds of rest after each working set. This shows us that the most common scheme for BFR in the guiding analysis occurred in 5 out of the 10 included randomized controlled trials. Cuff pressure also appears to vary quite a lot across the 10 articles. The lowest pressure applied appears to have been 130 millimeters per mercury, and the highest appears to be 200 millimeters of mercury. Reading through the article, we find that 80% of full closure pressure equated to between 110 to 186 millimeters of mercury. To be able to find the percentage of closure pressure, subjects' thighs were placed in a blood pressure cuff, and the cuff was inflated to 250 millimeters of mercury. This was done to occlude blood flow to the limb. The cuff was then deflated until a pulse returned. It was from the pressure where the pulse first returned that they determined each subject's individual pressure. When looking at the cuff pressure, they appear to vary, but that does not mean that their concepts vary. 7 studies utilized a mean cuff pressure that remained constant throughout the trial period. 3 studies adjusted the pressure of the BFR cuffs as their trials progressed. Iverson et al. Increased pressure daily by 10 millimeters of mercury, going from 130 to 180 millimeters of mercury by the end of the study. Siegel et al. Increased pressure weekly by 20 millimeters of mercury. They began at 160 millimeters of mercury and ended at 200 millimeters of mercury. The rest of the studies remained constant throughout the trial periods. Of the 6 studies that mentioned cuff width, only 2 studies utilized the same width, and they were performed by the same clinicians. It is important to mention that each of the studies utilized in the guiding review all used pneumatic cuffs for their trials. All pneumatic cuffs were also made of nylon. All cuffs were applied to the most proximal aspect of the thigh before being inflated to the desired pressure. Three main outcomes that were of interest to the authors for the guiding review included muscular strength, muscular volume, and perceptions of pain. Muscular strength was assessed in 9 out of the 10 included randomized controlled trials. Dynamic muscle strength was measured in 7 articles. Static muscle strength was measured in 3. Isokinetic system measurement was utilized in 4 studies, and isotonic measurement in 2 studies. Finally, a repetition maximum was utilized in 3 studies. Cross-sectional area and muscular volume were also measured. These outcomes were measured using ultrasound imaging, magnetic resonance imaging or MRI, computer tomography or CT imaging. Muscular volume was a primary outcome in 4 of the 10 included articles and was the only reported outcome in 1 of those 4 articles. Perception of pain was a primary outcome that was assessed in 6 of the included randomized controlled trials. Pain was measured with several different tools. 3 studies utilized the KOOS pain score. KOOS stands for Knee Injury and Osteoarthritis Outcome Score. 1 study utilized the WOMAC score, or the Western Ontario and McMaster University's Osteoarthritis Pain Scale. 1 study used the NPRS score, which is Numerical Pain Rating Scale. And 1 study used the Kohala Patellofemoral score. The major findings from this review was that low-load blood flow restriction is not more effective at improving muscular strength. It's not more effective at increasing muscular volume, and it's not more effective at decreasing perception of pain than conventional resistance training alone. That being said, it was also found that low-load blood flow restriction does have effects that are comparable to that of high-load resistance training. So what do we do with that information? Knowing that low-load blood flow restriction is not more effective, but is as effective as conventional high-load resistance training, there is an immense significance for clinical rehabilitation practices. This means that it is a great way to obtain desirable outcomes for patients who cannot perform conventional resistance training. Furthermore, it has been found to be more effective at improving subjects' outcomes after their injury than low-load resistance training alone. If we have a patient who can perform low-load resistance training and obtain low-load resistance training benefits, then we have a patient who can perform low-load blood flow restriction training and obtain the benefits of high-load resistance training. The clinical bottom line from the guiding review is that low-load blood flow restriction therapy is an extremely useful tool that should be utilized by clinicians. It's been shown to have greater effects than low-load resistance training alone and has been shown to result in comparable outcomes to conventional high-load resistance training. Low-load BFR can be utilized for both acute and chronic conditions to help mitigate muscular atrophy, mitigate weakness, and decrease perceptions of pain. Low-load BFR can be used for patients who are both pre- and post-surgical intervention. BFR should be implemented when conventional high-load resistance training is not a feasible option for their patients. Training should be implemented for a minimum of 4 weeks and should last up to 10 weeks. Training should occur 2 to 3 times per week. The 4-set 75 repetition scheme, or 30 repetitions in the first set and 15 in each set after, should be utilized with a 30-second rest period after each set. Repetitions should be performed with 30 to 40% of the subject's 1 repetition maximum for that desired mode of exercise. A fixed cuff pressure should be utilized at between 70 and 80% of the subject's limb occlusion pressure to help individualize each subject's treatment. Cuff width should be small enough to efficiently occlude the limb's blood flow, but wide enough to remain comfortable to the patient as they perform exercise. The guiding literature offered a lot of suggestions as to the effectiveness of low-load BFR. I think that future research should continue on the same path that this article went. We should continue to look at comparing protocols to each other so that we can determine the best one that works for each of our patients, regardless of injury. Future research should also continue to find if there's a better way to further individualize BFR to each of our subjects. Thank you so much for listening to my presentation. Have a wonderful day.